Welcome back to The Explainer. Today, we're diving deep into the diagnostic decision tree for Comitant esotropia. Now, as an ophthalmologist, you can't just rote memorize these conditions. You really have to understand the underlying anatomy, the physiology, and the pathophysiology. So by the time we finish this session, you're going to have a rock-solid mental framework to diagnose literally any esotropia that walks into your clinic and absolutely crush your OCAPs. Let's get into it.
Here is our roadmap for today. 1. Defining comitant esotropia. 2. Congenital ET without nystagmus. 3. Congenital ET with nystagmus. 4. Acquired accommodative esotropia. 5. Acquired non-accommodative esotropia. And 6. An OCAP rapid-fire review.
Section 1. Defining comitant esotropia. Before we start climbing the branches of our diagnostic tree, we have to secure the trunk, right? We need to differentiate this from a true neurological emergency.
So let's define comitants. A comitant esotropia is an inward turn of the eyes where the magnitude of the deviation, measured in prism diopters of course, remains the exact same in all fields of gaze. Now listen, this is a classic board trap. If a 60-year-old patient presents and their deviation gets worse when they look to the right or the left, you've got an incomitant deviation on your hands. You need to immediately stop thinking simple strabismus and start thinking acute neuro-ophthalmic emergency, like a cranial nerve 6 palsy. Comitance tells us that the extraocular muscles and their innervations are structurally intact. It means we're dealing with a supranuclear or anatomical misalignment, not some paralytic process.
Take a look at this pediatric patient here. Notice that massive inward deviation in primary gaze. It's roughly 50 prism diopters. That right eye is just buried right into the medial canthus. Now, if you track their alignment clinically through all 9 cardinal positions of gaze, whether they elevate, depress, abduct, or adduct, that exact magnitude of deviation is locked in. The medial and lateral recti are actually functioning perfectly fine. They're pulling the eye in a coordinated manner across all gazes. That unwavering stable stability is the absolute clinical hallmark of comitance.
Moving on to Section 2, Congenital ET without nystagmus. Let's head down our first major branch.
When a 4-month-old infant presents to your clinic in this branch of the tree, they're going to show a large deviation, almost always greater than 30 prism diopters. But here's the classic clinical presentation you absolutely must recognize: cross-fixation. Why do they do this? Well, if their vision is equal in both eyes, the infant intuitively avoids the active muscular effort of abduction. It's just easier. So they'll use their crossed right eye to view the left visual field and their crossed left eye to view the right visual field. It's a frankly brilliant biological adaptation. But you gotta recognize it in the exam chair because it very often masquerades as a bilateral 6th nerve palsy until you patch one eye and prove they actually have full active abduction.
You also have to check for latent dissociated vertical deviation, or DVD, which is a super frequent companion to infantile esotropia. Just imagine you're in the clinic doing the cover test on this kid. As you place the opaque paddle over one eye, you're observing that occluded eye closely. Because central binocular fusion is broken by the paddle, the brain sends a rogue supranuclear signal that causes that occluded eye to slowly elevate and extort right behind the cover. It's a classic hallmark finding, and you'll often see it present alongside inferior oblique overaction.
All right, let's pause right here for a quick clinical reasoning moment. Put your attending hat on for a second. If you're taking this infant to the OR for a bilateral medial rectus recession, what is your realistic surgical goal? And, biologically speaking, how is their immature visual system already adapted to this crossing? Take a quick second. Think about the pathophysiology here. Okay, here is the physiological why. The immature pediatric visual system is incredibly plastic. So, to prevent crippling double vision, the cortex actively suppresses the image from the turned eye. It just builds a central suppression scotoma. Furthermore, it develops anomalous retinal correspondence, or ARC, where the true fovea of the fixing eye actually wires itself to correspond with a non-foveal extramacular spot on the turned eye. Because of this early hardwired cortical rewiring, true high-grade stereopsis is permanently gone. You can't get it back. Therefore, your surgical goal before age 2 is definitely not perfect binocularity. It's monofixation syndrome, meaning a small-angle esotropia under 8 prism diopters with a tiny peripheral suppression scotoma. That right there, that is a massive clinical win.
Section 3. Congenital ET with nystagmus. Transitioning to our next branch now.
Okay, this is a classic board differential. You must know how to distinguish nystagmus blockage syndrome from Ciantia syndrome. Nystagmus blockage syndrome is a beautiful example of the body's built-in compensatory mechanisms. The visual system literally learns that active convergence dampens the constant sweeping oscillations of their nystagmus. So, by intentionally crossing their eyes, the child is maximizing their foveation time and ultimately their visual acuity. Now, on the flip side, Ciantia syndrome is defined by a very large esotropia. We're talking usually over 50 prism diopters, combined with a latent nystagmus that intensely worsens the very moment the patient attempts to abduct the eye.
Pay attention, this is a high-yield OCAP pearl. Lock this concept into your memory for the boards right now. Congenital motor nystagmus, or CMN, is not secondary to severe afferent vision loss. It's not a structural central nervous system pathology, it is a primary efferent motor defect. So if you evaluate an infant with a horizontal nystagmus, but their visual acuity is actually quite robust, you are very likely looking at CMN. Please do not over-image these patients if the clinical picture fits perfectly. Moving into Section 4, Acquired Accommodative Esotropia.
So when esotropia arises suddenly in a 2 to 3-year-old child, you've officially entered the acquired branch. Your immediate clinical imperative here is to rule out accommodative drivers. To really understand this pathophysiology, you have to master the near reflex triad. When a normal child focuses on a near target, their parasympathetic system executes 3 beautifully synchronized actions. First, accommodation, cranking in lenticular plus power via the ciliary body to clear up the image. Second, meiosis, or pupillary constriction, to increase depth of field. And third, convergence of the medial recti to maintain single vision. Usually our supranuclear divergence inputs balance this out. But in accommodative esotropia, the convergence drive is just so massive that it completely swamps the diverging mechanisms, yanking the eyes inward.
Please do not confuse these two variants on your boards. Let's frame this as a real patient presentation. If a 3-year-old presents measuring 30 diopters of esotropia at distance and 30 at near, you have a refractive accommodative esotropia. This kid is simply a high hyperope, say maybe a +4. They have to accommodate forcefully just to clear a distance image, which drives an equal overconvergence at all distances. However, if that exact same 3-year-old measures 15 diopters at distance, but a whopping 35 at near, they have a non-refractive accommodative esotropia. This is a pathology of their factory preset AC/A ratio. Their brain is just hardwired to produce excessive convergence for every single unit of accommodation. And since near targets require way more accommodation, their near deviation is going to dramatically exceed their distance deviation by 10 or more prism diopters.
Section 5. Acquired non-accommodative esotropia.
Let's build out our non-accommodative differential diagnosis for these acquired cases. Basic is pretty much just the acquired version of congenital ET, where distance and near deviations are equal but hyperopia is minimal. But here is your big clinical pearl. If a 6-year-old suddenly develops a basic esotropia out of nowhere, aggressively look for neurological signs, headaches or papilledema, and get an MRI to rule out an intracranial mass. Next, sensory esotropia. This happens when the brain is deprived of a clear image, like from a dense monocular cataract or corneal scar. Deprived of fusion, the cortex kind of abandons binocularity entirely, and the blind eye just drifts inward. Then we have spasm of the near reflex, which is a functional, often psychosomatic response. A great clinical trick here is that their abduction looks absolutely terrible when testing binocularly, totally mimicking a bilateral sixth nerve palsy, but it magically recovers perfectly when you cover one eye and test monocularly. Finally, consecutive is basically an apparent surgical overcorrection of a previous exotropia, and cyclic is this wild, rare, rhythmic condition where a child is profoundly crossed one day and then perfectly orthotropic the next.
Wrapping up with Section 6, OCAP Rapid Fire Review.
Well, we have climbed the entire diagnostic tree. Now let's tie all this physiology directly to your exam strategy. This matrix right here, this is your ultimate OCAP pattern recognition tool. By strictly analyzing the relative magnitude of the distance deviation versus the near deviation, you can instantly unlock the diagnosis. Equal deviations mean high hyperopia driving a refractive process. A dramatically worse near deviation means a high AC/A ratio is to blame. Simple, right? But I want to test your clinical reasoning with one final scenario. What if the distance deviation is significantly worse than the near?
Let's end on this classic board question. You've got a 70-year-old patient who presents complaining of double vision while driving. On exam, they have 20 prism diopters of esotropia at distance, but they are perfectly orthotropic at near. What is the diagnosis and what's the mechanism? It's divergence insufficiency. Unlike our pediatric accommodative cases we just talked about, this acquired adult presentation often stems from age-related structural changes to the extraocular muscle pulleys, also known as sagging eye syndrome, which physically limits their divergence. If you can remember this physiologic pattern and trust your diagnostic tree, you will confidently navigate any esotropia case that walks through your clinic doors. Keep reviewing, keep connecting the anatomy to the patient, and I will see you on the next explainer.